started. I'm Denis Roy. I'm a VP Science and Clinical Governance at INES, the National Excellence Institute in Quebec, and I'm the current president of CAHSPR. And I'm very proud to facilitate this concluding panel. We have a very strong feminine bias in the composition of this panel. I'm very proud of it. It's not common. We've been working on it very hard, but it was an easy task to select those right people, and we're very happy to have this input. We have 5 panelists, and the topic is moving from successful patient projects to full-scale implementation, and examining the role of regional clinical governance as a lever for that. And just as an introductory note, I think we have traveled a beautiful territory today. We have had access to a 30,000 feet perspective, definitely at the beginning of the day. We have had some helicopter sense of the perspective on a more meso level as well. We've explored the actual nature path in the woods at some point also. And we have certainly gained a better sense of what the map looks like. But I'd like to suggest that we have a group of people who could really be the writers of the Lonely Planet Guides chapters to understand how we will travel this. And the question really is it pertinent to reflect on such a role for regional governance, clinical governance? Is it feasible? What are the conditions to have in mind, and maybe some possible next steps? So that's the general topic of the panel. We will have more or less 10 minutes, maybe a bit less if it's enough. Joshua has gently agreed to be more concise. He's generally very much concise, so it's quite a challenge for him to se dépasser ainsi. And so we will be able to finish on as scheduled and allow for more discussions with the panel. So I would like to invite Nancy to start.
Okay. Well, thank you very much. And I don't have the benefit of having been here all day, but I understand it was fantastic, and I'm going to steal everyone's notes. But so if what I say doesn't completely follow from other conversations, I apologize. But what I do want to say is when Lee and Josh invited me to speak to this, I loved the topic, and I thought it's extremely on point with what we're doing in the ministry right now. And I think as everyone who's familiar with the Ontario health system knows, we're in the middle of a very large conversation about some restructuring for primary care and home care and the role of LHINs through the discussion paper that was released in December. And I want to acknowledge really the very big debt we owe to the HealthLinks experience. The HealthLinks concept and initiative was introduced a couple of years ago. The take-up on that, has been incredibly instructive, and Lee's always our data whisperer on that, and she and I have weekend conversations about what the data is really telling us. But what it is telling us is that there's incredible clinical engagement. When we put something out and we put that kind of request out, and one of the commenters and the questioners in the previous panel said, physicians and clinicians come forward. There's an intrinsic motivation on behalf of patients. And, I think we've been so impressed by the HealthLinks experience, a very low rules experience, as we know, and, a little bit of an uneven starting point across the province. Some parts are very well advanced and some parts are just getting going. But I think the discussion paper, it's easy to see how we're building on that experience. And I think one of the key concepts in the discussion paper, which is elegant in its simplicity, is the idea of organizing the health system around sub-LHIN regions. So in some ways, we are about to make a very big bet on regional clinical governance, because how those are conceived is the idea that we think about the health system in bite-sized pieces, right? So we stop thinking about the Waterloo-Wellington LHIN, and we start thinking about Guelph, and we start thinking about Cambridge, and we start thinking about North Wellington, and we think about the Champlain LHIN in 10 manageable chunks, which are wildly variable. When Central Ottawa is a lot different from Renfrew or from Cornwall, that kind of thing. you know, anyone who works with data knows that once you start disaggregating it, you know, averages are deceiving and they obscure a lot of dips and valleys. So I think the idea that we could put clinicians, you know, identify a lead clinician, a physician, a primary care provider, perhaps another form of clinician, as a lead clinician in each sub-LIN region, not as a substitute for the kind of clinical leads that have been really, really valuable at the LIN level for primary care and critical care and emergency care, but as a resource for both physicians and patients. And I'm going to get very simplistic about this, partly because we are in explaining mode a lot these days. What does this really mean? How will it change things for patients? Here's an analogy we use. Right now, the primary care system, it's like running the education system without school boards. If you move from Toronto to Kingston, it would be your job to go around from school to school and see if one of them will take in your child, right? You don't have to do that. You go to a school board and the school board finds a school for your child. You have some choices. If there's not enough grade 3 classes, when more grade 3 students show up, it's the school board's job to arrange for more teachers or arrange for the right school board. Right now, if you're a patient and you go from doctor to doctor and all the doctor's practices are full and you can't get in somewhere or you can't find the right kind of doctor, that's your problem as a patient, right? And that is what we are trying to change. So we are going to put the capacity that already exists into the health system and ask, you know, our LINs and our clinical leaders to help focus on how do we make sure that when patients show up at a door, we can help guide them to the primary care provider that's right for them and their family. From a physician point of view, you know, what's impressed me is how many physicians in the course of our discussion came forward and said they see value in this for them. And, you know, one physician who anybody in this room would describe as an insider said to me, if I have a patient and I'm trying to, and that patient I know has to move to another part of Ontario, I find myself asking myself, who practices there that I went to med school with, right? So that I can call them and say, help me get this patient into the cancer treatment she needs or the, you know, surgical treatment or the primary care practice. There has to be more of a system than who did I go to med school with, right? And so this physician said, look, the potential I see in this model is if there's a clinical lead for that sub-LIN region, I can call that physician and say, how can I connect? Here's my patient, here's the profile. We're missing that capacity right now. And I think we have that capacity, but we haven't sort of organized ourselves in the kind of sub-LIN regions with that kind of capacity on behalf of patients, but also to make all the clinicians and providers who work in the system make their jobs easier as well. So that's the value we see, and I'm going to stop there and hand off to the next speaker.
Thanks, Nancy. Danielle, please.
I think my comments are going to build actually really nicely on Nancy's. I'd like to speak a little bit from the perspective of a family doctor about where I see primary care in all this. And as a lifetime dedicated student of Tom Noseworthy, I'd like to try to separate out our structures from our processes and our outcomes here. So, you know, we're talking mostly, when we talk about regional governance, presumably we're primarily talking about structure, right? But for me, from the perspective of primary care, what regionalization has the potential to do is to allow a kind of process flow in the system around primary care that we haven't heretofore been able to achieve. And I want to touch on just 3 areas where I think we have the potential to really make a difference with regionalization, certainly in Ontario. The first is that once you have a regional structure, you effectively have the necessary but not sufficient conditions for integration with the other parts of the healthcare system and with social services. And although that sounds really sort of facile to say, it's not obvious currently at the moment. If you run a hospital and you're trying to figure out what to do with your people post-discharge and you know that they're not able to get into primary care, whatever that is, in your neighborhood, there is no phone number you can call to reach primary care in your neighborhood. In the absence of a regional structure, there is no receptor site. So you've got all of these, I picture these molecules, these integration molecules kind of like floating around in space looking desperately for some receptor to latch onto, and there's nothing there, right? And so what we need are processes that allow the flow of information, of people back and forth between primary care and the other parts of the healthcare system. And we can't, it doesn't seem that we can effectively achieve that through any other means other than regionalization, at least where we have failed to regionalize, we've also seen a failure of imagination to figure out some other way to do it. So I do think that the integration process can be supported by the regional structure in ways that are actually meaningful for trying to do those handoffs of patients between different parts of the healthcare system. The second process that I think is supported by regionalization when it comes to primary care is, I want to unpack a little bit this concept of spread and scale that I know this conference was intended to partially to get at. And again, Tom and others have spoken to the importance of this in their remarks. We know that we've got tremendous amounts of goodwill in the system and a lot of resource going into the kinds of quality improvement projects that we've heard about today. And there are institutions and institutes like the Canadian Foundation for Healthcare Improvement and others that are actively engaged, HQO, of course, obviously, and others that are actively engaged in this process of trying to scale up those models across the entirety of health regions or health systems. Insofar as our work is to try to spread around the learnings between different institutions, you don't necessarily, I don't think, need to have regionalization in order to do that, right? You can have teams learning from other teams, you can have people going out and doing workshops, and you can have reporting at whatever level you want to have reporting at. But insofar as you actually want to utilize the instruments of scale, and I want to acknowledge Jay Shaw and Josh Tepper in the audience who have been working with me and others on this concept, insofar as you actually want to impose some order on the system and have some requirements to participate in those kinds of quality improvement efforts, you actually need some kind of a regional structure to support that process. And so again, in primary care, we see lots of tremendous effort going on in little pockets across the system, and we see teams talking to one another to try to learn about best practices, but until somebody comes in and says, in our neighborhood, it's gonna be like this, and this is what we're all going to do together, it's very difficult to achieve any kind of progress. And again, I think that process of quality improvement or that process of scaling up success requires the structure of regionalization. The third thing that I want to touch on, and then I'll finish here, is something that I'm surprised I feel that we sort of danced around in a lot of our discussion today, but we haven't sort of taken on head on, which is physicians. We're not going to get to where we need to get until the docs are engaged, and people have said that, but the question is, how are we going to engage them, right? And again, in the absence of some kind of regional structure, it seems to me that we lack the basic processes for what effectively in the Canadian healthcare system amounts to a community organizing effort. And that is what I learned from watching the Health Links experience in Ontario, and from watching the Health Links that really did tremendous work. I'm thinking of Pauline Pariser, who leads the Health Link that my hospital is in. Watching her go around to the 400 solo practice family doctors in our neighborhood and literally knocking on their doors and introducing herself and saying, I am here to make your care of your complex patients easier. And this is the one number you can call when you need to get access to a general internist. And this is what you can do when you have a person who you think is teetering on the edge of readmission. And how can we reach you when we want to tell you that your patient has been admitted to the hospital? That is a community organizing effort. And so long as physicians continue to maintain our current sort of half in, half out, status in the Canadian healthcare system. Community organizing is the only way we're going to ever get the docs to participate. Certainly that's the case in primary care. And again, regionalization is the necessary but not sufficient structure that enables that community organizing process to take place. So I think from the perspective of integration and the provision of a receptor site for integration in primary care, from the perspective of providing an infrastructure for spread and scale across the system, and then finally from the perspective of engaging clinicians and particularly family physicians, it seems to me that regionalization holds tremendous promise, and yet of course is only one component of the puzzle.
Over to you, Gail.
Thanks very much, Danielle. Very clear. Gail, please.
Thanks very much. Hi, everyone. I'm glad to be here. I wasn't here all day, but I did participate listening in on the web, so thanks for making that available. It meant I could be here. I'm going to follow up a little bit, maybe get a little more granular, because my interest and my focus is primarily on home care. Home care hasn't received a lot of attention yet today, and at the risk of overgeneralizing, I'll say that maybe some of the challenges in delivering care to folks at home are different, and that those differences not only need to be respected, but systems need to be able to include different ways of delivering care than maybe they do. So my focus, apologies to those of you from across the country, is particularly Ontario-centric, but I think there might be some lessons to be learned. So I want to talk about a few of the challenges I see in integrating home care as a genuine piece and part of the system. I'm not going to quarrel at all with the benefits of regionalization and the benefits of clinical governance. I might have to ask the question before I even start, and I've probably been around longer than anybody here. We have been trying for many, many years to engage physicians in policy and delivery, and we have not been dramatically successful. We have pockets of success. I think we need to ask ourselves why that is, and we have to make sure we know what's going to be different this time. So a little bit the skeptic in me, and your example, Danielle, of knocking door to door, that's a long way from engagement. So with that general comment and getting that out of the way, because I'm not opposed to the idea of primary care being a center point. The paper the regionalization paper talks a lot about primary care physicians being the center point. Good, as long as we have them everywhere and they're all engaged. But let me talk a little bit about the challenges in home care now that I've got that off my chest. The first one is that, as was acknowledged, Ontario is a little bit different because there's the provincial, the regional, and then we've left not only primary care, but we've left hospitals out of this. So as long as hospitals remain independent with their own boards, there's no question that they will continue to scoop up the majority of the resources. And home care, that doesn't have the benefit of that strong lobby, for want of better language, will continue, in my mind, to play a role as the poor cousin who gets the hand-me-downs. I think in Ontario we're making tremendous strides in home care to make sure that doesn't happen. But just as when we haven't aligned and really brought primary care right into the lens, as I think Greg mentioned this morning, until that happens, it's going to be very hard to really have the kind of integrated system that we all talk about. Again, we're making progress. It's slow, but I'm just going to talk about the challenges today. The other thing is we're talking a lot about regional clinical governance, and the examples that have been used around integration and around patient engagement, which family engagement is something I feel quite strongly about, have all really depended on acute care in one way or another. It's been post-acute or something. Home care is different. Home care is not strictly clinical. Home care is not at the under the control of the provider. Even, as a matter of fact, you can't even get in to give any services unless someone lets you in. So it's a very different, it's a personal support, it's social, yes, there are clinical, but home care, and the bulk of people receiving home care whose support is coming primarily from their families or their neighbors, not from all of us, home care is different, and the difference really needs to be acknowledged. And I think, I'm not sure, I think it was Eve who made the comment earlier this morning around grand transformational change doesn't always make improvement or dramatic improvement. We need to watch structural change and function. If we're not attending to both, we're not going to have the outcomes we desire. So if any place, if we're thinking about levels of engagement, if any place co-design and partnership, real partnership, is absolutely necessary if you're going to achieve the desired outcomes, even defining the outcomes have to be a partnership. It's in home care. And I think we're working hard on that, but it is a big challenge when most of us, and I took the time to take a look at the key informants on the paper, most of who we consider to be key informants, leaders, etc., the bulk of their expertise and experience have been in acute care. It is a different culture. And my concern is not only with the system level, but very much at the micro level. What is the difference we're trying to make for people who are going to be at home? Because we've been kicking people home for a long time, and we owe it to them, now that we say we've got lengths of stay under control, we owe it to them to make some difference in the homes we've encouraged them to stay in or sent them back to, etc. The last comment I want to make is about change generally. And really, in the simplest language, we can talk about top-down and bottom-up. And most of the change, and Ontario has traditionally and been highly centralized. We're moving, maybe more slowly in some areas, more quickly in others, to regional models. And I think we've made, and you heard some examples, some really good innovative moves. And most of that has been top-down with a lot of participation and attempts at engagement of all the players. But it works more easily when acute care is the focus. It doesn't work as easily, I don't think, in home care. I think in home care, we really need to work a lot at the, I'll call the very functional level. So while we're working at the structural change, we can't ignore the really functional change that happened. It isn't just a matter of putting people in different places. It is much more a matter of helping people understand that where they find the client and the family at home is a different way of relating, a different way of delivering care. So while we're working from here at the macro level, we also have to work at the micro level to make sure people have the skills they need to engage appropriately with families. So I think I'll leave it there and look forward to more discussion. Thanks very much.
We hear very much the importance of adapting the strategies to the specifics of home care. That's a very strong message. Caroline from Quebec, she's actually leading a type 1 reform in her own setting. That's interesting to have her insights on the topic of the day.
Good afternoon, everybody. Jean-Louis told you this morning that he thought I was a little bit optimistic, which is good because I'm a born pessimist and a trained optimist. And you never hear of optimists who train to become pessimists. Quebec is unique and different. We always say that, and I'm going to tell you why today. A year ago tomorrow, we abolished all the regional health authorities. Yes, there are no regional health authorities, and we actually went on the eve of the implementation of the law and put signs to eliminate the name Regional Health Authority. So we are integrated health and social services centers with a population health responsibility. And we started this integration 12 years ago by creating the health and social services centers. And 12 years ago, the only instances or bodies or organizations that were not integrated were really the specialized centers for youth protection and disability and addiction. So in 1 year, we went on April 1st of last year from 182 to 33 organizations because there was another merger this past fall. When I started 35 years ago in the Quebec healthcare system, we were 900 separate organizations. So in the space of 35 years, with the different reforms that we've had, we've sort of decreased and integrated very slowly. So I won't say it's a big bang, but we are now in a two-tier system, which is really, really interesting. All the 33 presidents and CEOs are around the table every 6 weeks with the minister and his team, which makes for really interesting discussions. So there were 6 organizations that were not merged, and those are the large teaching hospitals and specialized institutes and the health services for the First Nations. So we have 13 integrated health and social service centers and 9 university integrated health and social service centers. And the difference between the two is if you have a medical campus on the territory that you are and you have a teaching mission, then you're a university integrated health and social service mission. I'm a teaching institution, but my university campus is in Montreal. And just to let you know that Laval is sort of the little island hat that sits over Montreal, and we have a population of we serve a population of 430,000 people. So there is one integrated health and social service network per territory, and they're called territorial health and social service networks, so the territory that we work on. And the exceptions are Montreal, where there are 5, and the South Shore of Montreal, where there are 3, because there were enormous regions with a lot of population. And the objective and the main goals are to do what we could not do with the last reform, is really create better continuity and integration. And when this law was adopted, a couple of months later, in November of last year, there was another bill that was adopted, which is specific for physicians to make sure that organizational goals and the goals that were set for family practitioners and specialists are aligned. And the reason why I'm optimistic is because in 35 years, this has been the first time that there has really been an effort to make sure that we have common goals and that we're working in the same direction. So for me, that is really, really important because we were always working at cross purposes because our goals were never aligned. So we're focusing, and our main role is to focus on local access to care and services in a given territory and work and to modify the relationship we have with our family physicians and with the specialists as well, because you have to work on both fronts. So specialized medical care and family practice. And the focus is to make sure that we really have, for the first time, incentives to ensure that there is better access to family medicine in the community. Because we instituted about 12 years ago what we call these central referral gateways or guichets that were designed to permit patients who were looking for a physician to register, and they're looked at by a nurse, and then there's an acuity and vulnerability level assigned, and then they're put on a priority list, and the family practice physicians and clinics were able to phone us and say, look, I'm looking to register patients in my territory. Can you refer me the names? And so we're making this referral actually easy, except that we discovered that they were taking the healthy patients and the vulnerable patients, the ones with mental health problems, the elderly, the ones with chronic diseases. We would have a really hard time to get them referred into a clinic. And then we have to change the relationship within the hospitals between the family practitioners and the specialists, because aside from university teaching hospitals, in Quebec, regional community hospitals have been supported really in their backbone by family practice physicians, and the specialists were consultants. And so this dynamic has to change, because in order for the family practitioners to go back into the community and put more hours in the community, they have to do less hospital work. And as a matter of fact, in December, we all received a letter from our Minister of Health who said, as of today, you have 20% less. You must make a reduction of 20% in your physician family practice presence in the organization. Now, fortunately, I had made a manpower plan 2 years ago and brokered a deal between our family practitioners and our specialists so that we could shift the number of beds that the family practitioners were responsible for and that the specialists would take over, so that more and more family practitioners could return in their community. So the one thing that we have, like I said, aligned goals, but we also have clear expectations and metrics. And these expectations have been given to the physicians, and they have 2 years to comply. And if they do not comply voluntarily, as negotiated between the ministry and their federations, then it comes into law. And so they have volume requirements, individual and collective. We're expanding family practice clinics on each of our territories, so they have to work in family practice clinics ideally. And the distribution has to be geographically equitable. And we, the organization, have to provide them with professionals. In the last 10 years, the Health and Social Service Center has provided them with nurses, and now we're putting a multidisciplinary team to work and support these physicians. So just to give you an example, we're going from 10 family practice clinics to 12 in a new certification process. We used to provide about 33 nurses to support the work in these clinics, and now in addition to the 33 nurses, there are going to be 33 other professionals, social workers, kinesiologists, nutritionists, pharmacists, to really create an interdisciplinary team. So we're really positive about that. The other thing that I'm doing and that the other regions are doing is we're working very, very closely with what we call our Regional Department of Family Medicine, because each region has a Regional Department of Family Medicine, sort of like a Department of Family Medicine in the hospital. So automatically all the family physicians are a member of that department, and that department reports to me, to the president and CEO, and we have an executive committee, and we work on aligning our goals and what do we need to do together so that you can pick up more patients, more vulnerable patients. They also have to meet requirements for advanced access because the physicians will get penalized if their patients come to the ER instead of going back to their clinic. So we're starting to see that something is happening and something positive is happening. So that's why I'm really excited. And I think my 10 minutes are up.
Thanks, Caroline. I think we have a context that emulates the structure that you were referring to, Danielle, in a creative way, you know, with lots of authority on it, and it's being negotiated as a bill, you know, and very strong public negotiations and public reporting. So there's much energy into this, but it leads to a new context which might be amenable to some clinical governance work. Jeffrey, please.
Thank you very much. I'm not really sure what to say now that I've heard lots of questions. We've gone from increasing the number of units in regions to actually decreasing. So I'm not sure where we're going to end up in the regionalization game. But what I wanted to do today with you is take just a few moments to take the perspective that Health Quality Ontario has been trying to address, and that's how do you build quality into these the regional circumstances and have the right clinical quality governance structure to make sure that that's a reality. And part of that process, when we started to think about what the structure might be, was we went out and spoke to many of you actually in the room and others, and it was clear that there were several important themes, and I thought I would just highlight them because if you're trying to solve a problem, you better figure out what the problem was that you want to solve. Otherwise, you're just going to have redundancy. So we heard repeatedly, and I think you're all aware of it, that the system's clearly fragmented. We've talked about that. Quality and our initiatives in quality are fragmented. There doesn't seem to be a plan. There doesn't seem to be overarching governance, management, direction, cohesion of the quality initiatives. And in fact, there's many different quality initiatives underway. It was more sense of how do we coordinate and focus those and provide the necessary support for them at a local level. The next one was that we were very poor at generalizing successes. And so just as Danielle has mentioned, that sense of scaling and scoping of our initiatives, I think that there is a challenge with that, and that we think that if we just merely, it's like going and getting a program or something and putting it into your computer or whatever it might be, downloading it, it's not. And that's why we fail. It requires it because it's so regional. You need support resources to implement it. You need training to implement it. And it won't be the same because you're implementing it in a different environment. So it's not quite as easy as one might think. The next one is that old phrase, all politics is regional or local. This is what we heard today from Sarah, is that everything you do in terms of health service delivery is regional. And quality has to be done at a regional level as well. And whereas we might have many different provincial initiatives, we have to drive down quality right into the regional areas and right into the individual practice. And frankly, the infrastructure doesn't exist at that level. And we have to provide the data, the leadership, the capacity building, the support, so that they can measure and adjust and develop their own unique quality initiatives. Yes, derived or driven by overarching provincial directions, but coming as well from the local circumstance. Engagement of clinicians, we heard that repeatedly. How are you going to get the clinicians engaged? And I think when you talk to the clinicians, they would say, well, they have been disempowered historically. Now, that might be an excuse, that may not be, but nevertheless, clinicians historically had not been part of the game. And in fact, they often stood outside When they didn't like it, they threw grenades in, and that's where it sort of ended. And so, I refer to that, I can speak from the physician part of that, but I think that's more widespread than just physicians. And then the last one was, how do we build this culture of quality at a regional level? So that quality is about everything we do. It's not something we do on the side of the desk at 5 o'clock and, oh boy, I've got to fill out this form and collect some data and do an initiative. It's got to be the DNA, the oxygen that we breathe. It's got to be part of what we do. So how do you actually build that at a local level? So we, in partnership with the LINs, Lee was very instrumental in working with that, and the ministry as well. We've thought, well, let's try and develop a system of creating regional quality tables. And those regional quality tables would have the mandate to try and promote quality initiatives that would be the integrator. So that would be somebody who would have create that regional quality plan, could bring all the different partners together, that would be accountable for some of the quality metrics within that area, and would have the regional context in mind, and at the same time would be listening to what's happening provincially, but also telling provincially, feeding that information upwards so that the provincial organizations would be able to react to actually what's truly happening on the ground. And so that was the sense that we would try and create these regional quality tables, and we're in the process of doing that, and they would have to link within the structures that we have that are evolving of LINs and sub-LINs. And that's been a very positive, we've had, of our 14 LINs, all 14 have put up their hands and said we're all over this, and we're well on our way to developing that. But at the same time, we're creating a provincial coordinating structure where we could, again, bring the provincial leads together and say, what's happening in quality? What's the agenda? Who's accountable? Where's the capacity that we need? How are we going to make use of our scarce resources to promote quality? And who are we going to hold accountable for achieving the metrics that are required? So for the first time, we would link regional activity, integrated regional activities, driven by regional needs, to provincial activities where policy, resources, and capacity and leadership could come down and support the regions. And I think that that's a winning proposition. I hope that that's going to be very effective as we move ahead in promoting the quality agenda. The last thing I'd like to say in the minute that I have or two that I have remaining is that it relates to the issue of quality, and the caveat, the concern I would have is if we just create another level of governance, if we just create another committee, often we say, done, we can walk away now. And then what you're going to do is just have another committee and another level of governance. And I think if we were to think about failures in the past and reflect on how things have not worked, is we haven't really truly been inclusive as to who you put into that group. We haven't truly been aligning the resources that you have to the outcomes that you want. We really haven't done that. We haven't consciously developed capacity and leadership to get the goals that we truly want, that are focused on the needs of our unique communities. And we haven't created that culture. And that's going to take a long time. And as I think Danielle mentioned, necessary but not sufficient. It's necessary that we have the appropriate governance structure. It's insufficient alone. It won't do the job. It'll be ineffective, as we've seen so often in the past, unless we follow that up with the appropriate alignment, resources, leadership, capacity, and accountability. And we make it a reality.
Thanks very much, Jeffrey. We have a question, and we'll start with the Iman's question. It relates to capacity and workforce planning. Does Ontario conduct health workforce planning to ensure that these initiatives are possible, that workers are there and are going where they are needed most? So it has a workforce planning piece, but I'd like you to discuss also the capacity building piece, because they are so closely related. Nancy, would you like to start on this one?
Sure. Well, the answer is yes, to a degree. And I say this as much from a previous role when I worked in post-secondary education with the Ontario government, is that we do look quite carefully at, for example, the health capacity in our colleges and universities. So med school spaces are very carefully planned, specialist spaces, all the other types of clinical roles that students need to be prepared for. So, I think the provincial government as a whole looks quite carefully at saying what's the population needs, what's the enrollment levels, are they in balance? I think once a professional or a clinician is at an entry to practice stage, it plays into a little bit of our capacity planning. Who do we have in different parts of the province? What is the patient need? What are the patient demographics? It's tough. You can't produce in a perfect world, we'd be producing geriatricians at the same pace that people are turning 65. So we'd be generating, 3.4% more geriatricians every year for the next 5 years, because that's the pace we're on. Doesn't always work perfectly that way, and we know we have gaps, and we have an agency called Health Force Ontario, and they help us, match clinicians and the geographic spaces and that kind of thing. But there's always challenges in health workforce planning, and it's a big part of the capacity planning, apart from just our physical assets. Our human resource assets are essential.
Any additional comments on this?
My comment would be more, not so much about at the provincial level, but I think we still have lots of work to do. I think I can say this because I'm spent a lot of time in academia, but I think we have a lot of work still to do in the education and training of healthcare professionals, both in terms of helping them understand the system that they'll be going into. So sometimes the match between the person just completing his or her training in terms of expectations of what kind of system they're moving into and the system that is going to exist in the future. There's not a good match there. And frankly, I'm not uncomfortable holding myself and lots of other academics responsible for that. So a lot more focus on the skills required to do the work, and not enough attention being paid to actually, you're going to be part of a team, you're going to be part of a system, and you're going to have a role in that.
Jeffrey?
At the sake of being controversial, I think we've spent too much time thinking about the number of different professionals as opposed to what those professionals are actually going to be doing. And I think there have been legislative, regulatory frameworks that are no longer serving us, and that we have to start to think about what are the tasks we need and who's best to do them, and not be bound by the same regulatory challenges. If you need somebody to educate your patients about nutrition, healthy lifestyle, smoking, personally, I wouldn't ask your physician to do that. We've got a whole bunch of unemployed teachers around. Why would we not have those unemployed teachers who are skilled educators, very good at counseling? Why wouldn't we give them some additional training skills in health education and get them doing that as part of integrated teams and allow the flexibility for that to happen?
We focus on needs and finding the best answer to meet those. Danielle?
Just two quick stories to illustrate the complexities of this. One is that I had, as a VP medicine, a young surgeon in my office. I'll keep the flavor of surgery untastable for the purposes of this example. This young surgeon was in my office looking for a job, just graduated and was off to do a fellowship at a fancy place out of the country, and was hoping when she came back that there would be a job for her in my organization. And I said, well, what are you going to go and do your subspecialty fellowship in? And she said, well, I was thinking I would, I really enjoy X, Y, and Z. And I said, well, are you aware that there's a 2-year wait time in our neighborhood for A, B, and C, which is another option? And she said, no, that's interesting. That sounds like that'd be fun too. And I said, well, what if I were to ask our Lynn to send you the data about where the needs are in our local neighborhood? Because if you went off and got trained in that, I think your chances of getting a job here when you come back would be much higher. And she said, what a great idea. It had
Out of the
never
box.
crossed her mind. And why should it, right? Why should it cross her mind that she has some, personal obligation? I mean, neither are we pushing that data or that information out to our trainees, nor are they asking for it or taking it into consideration in any kind of a serious way when they're making their career choices. So, this person's now off doing her fellowship training, and maybe when she comes home, there'll be a job for her, unlike many of the other unemployed specialists we see roaming the streets of Toronto with a bunch of very highly specialized skills that we don't happen to need, at this particular time. The second story is that, we had a situation in our neighborhood where there were extremely long wait times for cardiology, to which you would say, well, obviously we should be training more cardiologists, just like maybe we should obviously be training more geriatricians. But we now have some cardiologists in my organization who, instead of seeing my patients, are happy to take a phone call from me. And guess what? It turns out we don't need cardiologists, right? And it may turn out, and I don't want to be overly controversial here, but it may turn out actually that we don't need geriatricians either. It may turn out that what we need is somebody on the other end of the form to support the primary care provider in providing that service in a much more localized, holistic way. And if you're providing that back up to primary care and then setting clear expectations for what the primary care providers should be doing for that population, it may be that the mix of, and I don't mean to be picking on specialists here, like it's equally true of the entirety of our interdisciplinary teams. I think that we need to think a little bit differently about our workforce planning in order to make sure that we're taking into account the very many different ways in the 21st century that we can be coming together to provide care to the population.
Okay, we have time to entertain a question from the floor. Any request? Tom, please.
So today the word accountability has been used a number of times, and there was a brief exchange a few hours ago about whether it should be in a contract form or not. This afternoon we also heard the word social contract. And I'm not aware of any, but certainly not many, social contracts in this country between physicians and patients. So that's the question. At the provincial level, do you think the time has come, and it will be of any value, to have a social contract between the physicians in a province that are paid well from the public and the public itself? That's the first question. The second question, what payment model would you think would be the best one to help support that?
Certainly a blended model. That's always the right answer.
So you would not get rid of fee-for-service? Yeah. So a lot of people often answer, well, let's just get rid of fee-for-service. Look, fee-for-service is a very important way of paying physicians, so I'd hope that would be in your menu of the payment model and the blended payment model. But is a social contract, are we ready for it? Is it necessary? In fact, don't the Canadian public deserve it? In Alberta, we pay $3.4 billion to our physicians every year, and there's not a shred of accountability that we could actually recite, and there's nothing written down. Shouldn't it be better than that?
Please, Jeffrey. He volunteered, actually. I've observed this show of hand.
I'm just, thanks, Tom, for that easy question, and I'm just about to announce my retirement. What you're asking is, should there be a formal social contract? There is a social contract. Sometimes we forget that social contract. There is a unwritten social contract between physicians and their patients one-on-one and professionally. We take that oath. I think many of us take it at the time of graduation, etc. However, I think that should be explicit. So that's what you're talking about, Tom, is should we make that much more clear? What our role should be in explicit fashion, so that when we have our one-to-one with our patients, or when we are dealing with communities or populations, that we say, we have an obligation to you, and we're here to serve you. That's our job. And I think that should be explicit. I think we as physicians should be standing up and saying that. I think we should be all saying that as all providers and saying that. We're here to serve, not ourselves, but to you. And if we're not serving you, and if you don't feel that we're serving your best interest, we should know about it. And I think it should be explicit.
We'll be piloting the contract at the Ottawa Hospital and Women's College Hospital as two local pilot sites from which to spread and scale.
By the way, Tom, we have what we call a physician agreement that was driven by the physician body at the Ottawa Hospital. And that outlines our commitment to our patients and our commitment to the hospital.
How much patient input went into that, Jeff?
We actually had patients on the committee, and it was driven by the doctors. We reacted with the hospital, but we also, on the one side, this is what we're going to deliver. The other side, we negotiated with the hospital and how they would handle us and deal with us and how they would respond.
And Jeff, maybe for people, because I think it is a very interesting document to talk about how long it took, like it was not overnight.
Oh, no. Yeah. No, this took probably, it was an iterative process over 3 years probably. Later on, I'll show you the scars.
Please, we'll take another question from the floor.
Thank you. This may be more of an observation than a question, because it's really interesting having heard the flavor of the day. And I think one of the key messages that I'm taking away from all of this is this morning somebody made the reference about the need for top-down and bottom-up, that need to connect. Another phrase I'd put there is the done to and the done by element as well. So the theme today has been advancing quality through regional clinical governance. And one of the key, I think, truths about advancing quality is that people need to want to do that. That's the bottom-up part, the done-by part of it. The clinical governance is kind of like the backstop. So if I can just reflect on the experience in the Association of Family Health Teams of Ontario with our family health teams in advancing measurement through that. So, sorry, I just went to the name block.
George Southey?
Yeah, no. I wasn't thinking of George. Danielle, sorry. I was thinking, I'm in that age, where I was going Diane, Denise. No, it's Danielle. Okay, was making reference to that need for regional structures. And that really underlines, like, above all else, there's the need for structures that bring people together. So just as an example, in the way this has been approached is that we have partnerships. We have regional partnerships to advance measurement. And just that, in and of itself, has been a great motivator and a great supporter for people to do this willingly. And so we've been able to engage, the vast majority of the teams to be able to do that. Does that take you the whole way? Well, then you need probably some governance part of that. But that's the thing that I found the most interesting is just that, call it attention, or call it the duality that needs to work in concert of having that bottom up and the top down. Thanks.
Thanks for the comment. Maybe we could take a last... Oh, yeah, you're right. Thanks for helping me doing my job correctly. So please.
I have a question that's a bit more specific to Madame Barbier's presentation about the Quebec. So I don't know if maybe your question aligns more with the last comment. Mine's a little bit more specific, if you want to keep
Go specific, please.
Okay, specific. So I'm a graduate student at the University of Montreal, so I've been very much in touch and tune with the reforms that have been going on in Quebec. So I've actually been quite critical about the reforms that have been going on. So throughout these past 2 years during my grad studies, my master's program, I really had the privilege to speak to a lot of doctors working in CLSCs, and I've seen the transformation from what it was before the old model to the changes after April 1st of 2015. And if I could just formulate 3 critiques that I've heard, is that now with the territories that are now much bigger, the regions that are much bigger now, there's a much bigger catchment. And doctors do feel like they're now less and less in touch with their populations that they do need to serve. Another one too is that they do feel like doctors do feel like they're going to have to be much quicker with their patients. They won't be able to know them as well. So in general, their critique is that they feel like there is a désaccord. There isn't a balance between what's going on at the top, the reforms that the minister would like to or has implemented, and what is actually going on at the bottom when they are providing care. Anyway, all that to say is that in light of today's discussions, at the end of the day, we're talking a lot about quality. And when I think back to Quebec and what these reforms are doing and stuff like that, I'm thinking, well, what's a quality indicator in Quebec? What do we say when we want quality primary care? And what comes to mind is access. With the list GACO, these lists where we really want to make sure that most Quebecers do have access to a primary care physician, is just access, access, access. So I'm wondering maybe, Madame Barbier, if you can add to how the Ministry of Health in Quebec is defining quality of care.
Well, that's a really good question, and we're looking at that very carefully. But if I go back to the primary care physicians, and yes, I mean, we are talking about access because it has always been a problem, and it has been a problem for a long time. But we're also talking about continuity of care, and that's one of the reasons why, with the new program, to support family practice clinics that is starting right now, April 1st. There is going to be an interdisciplinary team working with the physician in the clinics. So we're moving people from our organization that used to work in teams without a physician, because that was the great divide in Quebec, was we had these local community health clinics that were supposed to have physicians 35 years ago, and the physicians decided that they weren't going to come. A couple did. So we've had this fragmented care with lack of interdisciplinary care, lack of continuity. So I think that when you're talking about people that have chronic diseases and the vulnerable population, you need to be able to have a team working together. So I think that's going to be one of the important improvements. Now, how are we going to measure that? That's the big question, because we can measure the numbers, but is that in fact going to change the way patients' health evolves? Are they going to be readmitted less into the hospital? Are they going to come to the emergency room less because they're cared for by a team? Those are the things that we're going to be looking at. And those are embedded in the new contracts.
I'm afraid our time is up, and the discussion is very interesting, and we have an online question, and I'm a bit aware of the fact that we won't be able to fully discuss that, but I'd like to invite Nancy's comment on this, because it relates to the professional entrepreneurship that was addressed early on today. And the question is from David Kaplan. Is it possible in Ontario to support community-based clinical integrative networks by directing monies from system quality gains back into community sector? So would it be possible to revise the money flow to incentivize even more actively the improvement process? Just a reflection, Nancy.
Sure. You know, the answer is yes. I mean, it depends on the details of the proposal, but I think within the infrastructure of, a fairly sophisticated funding model for hospitals, a fairly well-established one for long-term care, an evolving one for community care. You know, we've been, I think, receptive to ideas for bundled funding or reinvested savings, that kind of thing. So, we depend on the details of the proposal, but, we've done bundled care, we've done other models, and we have a whole team of funding model designers, and they love a challenge. So,
So please, David, we'll provide you with the phone number so you can pursue the discussion. Well, thanks very much to the panelists and to the room.
We made a strategic decision earlier, actually, given the richness of the panel and the chance of discussion, to not do a big wrap-up. So we thought we'd save 5 minutes. I see we've saved 1 minute. So I had 8 profound, transformative thoughts, but I will spare you. I want to do really just 2 things. The first is to thank CAHSPR, to thank all of the partners who came today, to thank particularly Sally. Putting on a conference like this is just an operational exercise, and just a lot of time and thinking goes into pulling together phenomenal panels like the last one and like the ones we've had throughout the day, and the great speakers, the tremendous work that went into the foundational paper behind this conference. Really, literally just probably a couple hundred hours over the course of maybe 9 months leading into today. So just a big round of applause for all involved. And I guess the one thought I would say is that one of the things that did strike me today, and I'll spare you the other 7, is just the numbers of times that we've heard the word positive, promising, optimistic. And actually, if you pause on a minute and remember that this is a healthcare conference, that's somewhat striking. And you had sort of said you've never seen sort of an optimist be trained to be a pessimist. I would say many of us who have entered healthcare have occasionally found ourselves having gone from optimism, trained by the system and the experiences, into being a little bit pessimistic. And the fact we can come together and talk about primary care and home care and regionalization and funding renewal and differences in models of care, and to do that through the lens that starts with a sentence, I'm feeling optimistic, I'm feeling positive, is actually a remarkable state to the people who are here, but actually to where the healthcare system is going. So thank you very, very much.